Just update, we'll be having lunch against the barcode getting scanned from 12 to 1, but we will be closing the lunch around 12:45 because if there is too much noise in the pre-function area, it would impair with our program. So please have your lunch appropriately. There will be a 12 to 1 lunch time. With these words, may I request Dr. Shomobroto Raichaudhuri once again over the podium for Meet the Expert session. Over to Dr. Shomobroto Raichaudhuri.
Thank you. It's been a wonderful invitation from the part of the organizers to me to conduct this session. So this is the American Diabetes Association standard of care. And as you see, this is a new guideline, and the experts are also busily discussing amongst themselves about the new guideline. Screening for risk of prediabetes and type 2. Professor Shah, I think you have a better vision here.
No. Okay.
Okay. Then you can shift on to that chair. It will strain your neck a little less. Screening for risk of prediabetes and type 2 diabetes with an assessment of risk factors. Actually, the topic was what's new. But the things that are new are so new, 90% of them are not available in India. So I have picked up pertinent points. And also I would request the audience to please put their hands up and ask any questions in between. We want it to be interactive. Screening for risk of prediabetes and type 2 diabetes with an assessment of risk factors or validated risk calculator should be done in asymptomatic adults.
Yes, I think.
So, wait. এটা প্রফেসর শাহ পুরো ওই मैंने तो दूसरा हाथ अभी तक नहीं लगाया মতো একটা দিয়ে দিলেন तो what are the validated risk calculators for the Indian population? What are the validated risk calculators for the Indian population?
I think there are a lot of calculators nowadays available in internets. I think among that, I think if you calculate the risk of type 2 diabetes or the asymptomatic type 2 diabetes, I think first and foremost you have to see the problem is that for the pre-diabetic and type 2 diabetes for the screening purpose, I think probably the patient is not florid diabetes as far as the patient is concerned. I think patient does not know that patient is having pre-diabetes and or the diabetes. And in this group of the patients, I think according to the guidelines, if the age is more than 45, we have to go for the screening every 3 yearly. But before that, in Indian subcontinent, what happens, I think we have got a lot of other areas like the genetic factors, like the factors regarding the obesity, like the factors regarding the hypertension, physical inability, and all these things. That's why we have to do the screening test and something like that. Among that validated, obviously the BMI is one of the calculator where we can see whether the patient is actually having the obesity or not. Waist-hip ratio, this is also another validated risk factors or calculators. And another is the ASCVD score or risk factors to see whether the long-term complications regarding the hypertension or not, or the cardiovascular complications. And another risk factors calculator, like you can see the HbA1c, you can go for something like that. So these are the things we have in our armory, and we have to use all these things in a judicious way, depending upon the patients, depending upon the status, and depending upon all these things.
Professor Mujumdar,
আমি অ্যাকচুয়ালি কোনো ক্যালকুলেটর ইউজ করি না, দিস ইজ এ প্রথম কথা। সো দিস ইজ আমেরিকান ডায়াবেটিস অ্যাসোসিয়েশন গাইডলাইন অ্যান্ড দে হ্যাভ অ্যাডভাইস দিস। মাই টেক ইজ all Indians is high risk of development of diabetes. We have roughly 10% of our adult population suffering from diabetes. So therefore, it is prudent that we check every adult person for diabetes once in a year. সো এরকম তো নয় যে বাজারে গিয়ে বসে বসে সবারটা টেস্ট করব, বাট হুয়েভার কামিং টু ইউ ফর এনি ট্রিটমেন্ট, ইট মে বি ফিভার, ইট মে বি পেন ইন দ্য থাই, it may be neck pain, whatever maybe it is. If the age is more than 30, we should always check blood sugar, at least fasting plasma glucose once in a year, and spread the awareness that you should check it once in a year. The calculator, I personally don't use. আমাদেরটা ওই মোহনের একটা ক্যালকুলেটর ছিল, বাট again doing this in daily clinical practice when you are seeing patient in OPD or your clinic is basically not possible. So better write fasting plasma glucose as monitoring for every adult Indians. And in case of children, if there is an obesity family history, there is a separate issue. But adult means you can start after 20. কেউ কেউ বলে কি 20 পরে বছরে একবার নাকি একটা স্লোগানও ছিল, তো যাই হোক, কিন্তু অ্যাটলিস্ট আফটার দ্য এজ অফ 30 উই শুড চেক।
Yes, I think it is depend upon the clinicians to see the patient, and if it is required, I think you do the screening.
Yes, please. It is Kolsan.
Dr. Ganguly, sir asked whether what we should check 1 hour PP or fasting.
1 hour? No, 1 hour, I'm against 1 hour. A lot of proponents in favor of 1 hour. কিন্তু আমি যদি আধ ঘন্টা ধরে একটা খাবার খাই, এখন 1 hourটা কোথায় দাঁড়াবে আমি ঠিক জানি না। দ্যাট ইজ মাই প্র্যাকটিক্যাল পয়েন্ট, ইউ সি, লেটস বি প্র্যাকটিক্যাল। সো 1 hour নয়। If you are a purist, it should be fasting and PP both, because 1/3 of the patients with diabetes we will miss if we don't check PP sugar, particularly in the Indian subcontinent. But if you want to do a 1 point blood, একবারই রক্ত নেব, তাহলে ফাস্টিং সুগার HbA1c দুটো মিলিয়ে হলেই হয়ে যাবে।
1 hour means 1 hour after taking glucose, so there is no question.
1 hour, it is not only the diagnosis, when you are monitoring also there is a question about monitoring blood sugar levels based on 1 hour PP. So that will be 1 hour at the start of the meal, not glucose, when you are monitoring, because patient is known to have diabetes. Let us be absolutely clear about this. Diagnosis টা আলাদা, and that is the WHO এখনো embrace করেনি. It is 0 and 2 hours.
So now
I think what Kollan has said, we must be very clear. The diagnostic criteria is different, and how you are monitoring your patient in your clinical practice is different. For the diagnosis, yes, 2 hours 75 gram glucose you can do. Usually we don't do, we do fasting and HbA1c, that is good enough, but you can do, I agree. But when you are monitoring, পেশেন্টটা অলরেডি ডায়াবেটিসের ওষুধ পাচ্ছে, এইবার পেশেন্টটা কেমন আছে সেটার জন্য গ্লুকোজ কোনো সময় দেওয়া উচিত না। হোয়াট এভার দ্য পেশেন্ট ইজ টেকিং রেগুলারলি, যা খাবার খাচ্ছে তাতে কি সুগার কন্ট্রোল আছে, দ্যাট ইজ দ্য কোশ্চেন। তো গ্লুকোজ দিতে যাবো কেন, গ্লুকোজ কি রোজ খায়ও?
coming to the second point. Consider screening people for prediabetes or diabetes if they are on certain medications such as statins and thiazide diuretics. I am setting aside the HIV part of things. My question is, if a person is on statin or a thiazide diuretic, is there any particular duration of therapy after which you start to screen? And any particular statin which is said to be more associated with the onset of prediabetes or diabetes? Anyone? Anirbandha, start with this side, so that everyone.
Duration,
Short comments.
I don't know, but after what duration should screen? I have said that everyone should screen. আর যারা নাকি hypertension আছে, because you are giving the diuretic. If the patient is dyslipidemia, that is why you are giving statin. So patient should be screened every year at least. That goes without saying. It is not basically because of the fact that the patient is receiving hydrochlorothiazide, or because the fact the patient is taking statin, I am actually evaluating. I will otherwise evaluate every year. There is no point. Any particular statin, I think pitvastatin
Yes.
is
As a
basically
list.
do not cause
Least
possibility, but otherwise all statins are more or less similar.
Screen people for diabetes within 3 to 6 months following an episode of acute pancreatitis and annually thereafter. Screening for diabetes is recommended annually for people with chronic pancreatitis. Now let's come to how often you see the gastroenterologist or the physicians following the mandate of 3 to 6 monthly screening or annual screening thereafter, starting from Kolanda.
That is the bottom line. We should be doing with the patients come to me. They certainly I do, and I think all the physicians who are involved in
Somebody who has
diabetes
had a
care
gallstone pancreatitis and the gallbladder
will
removed.
do.
Okay, thank you. Any questions from the house? Anybody with a gallstone pancreatitis, gallbladder removed, still 3 to 6 months after the episode of pancreatitis, acute pancreatitis, and thereafter annually should be done. Post-transplant diabetes, in absentia we are not taking this question, I'll come back to this later. He's coming like Amir Khan to grab the Pepsi. Pharmacologic interventions to delay type 2 diabetes. Consider, under this, there is a thing, consider periodic assessment of vitamin B12 levels in individuals receiving long-term metformin therapy, especially in those with anemia or peripheral neuropathy, and India being a lot of people are vegetarian, so that is another contributing factor. What's the dose of metformin and duration, and should we screen for anyone even on 500 milligrams of metformin? বলছি কত ডোজ অফ মেটফর্মিন খাচ্ছে ফর কতদিন?
For B12.
Yes.
I think it is not clearly written in everywhere that how much metformin is required to produce this vitamin B12 deficiency, number one. So the thing is that as a clinician, if you have the finding of any peripheral neuropathy or signs of anemia, then you have to do the test like vitamin B12 and something like that.
Somebody without that 10 years on metformin, would you do, would you not do?
I think it is not clearly written in any recommendation that you have to do the
That's
annually.
why we are asking the experts.
So that's why it is recommended as a B. It is not A. That is, it is not clearly written in everywhere that it should be doing the vitamin B12 every annually when the patient is on metformin. Probably all the patients have on the metformin in every diabetic patients. Did we do the annual vitamin B12 in our patients? I think no. My answer is no.
Few points to be noted. So, patients with symptom of neuropathy, the neuropathic symptoms of B12 deficiency is separate from that of diabetic neuropathy. Diabetic neuropathy is mainly starts with the lower limbs first. B12 might be in the upper limb, it is the posterior column, so it's a bit different. Secondly, B12 deficiency একটা লোককে করানোটা খুব মুশকিল কারণ আমাদের সাফিসিয়েন্ট স্টোরস রয়েছে সো ফর পিপল হু আর নন ভেজিটেরিয়ানস ওদের B12 ডেফিসিয়েন্সি করানোটা একটু মুশকিল অনেক দিন ডিপ্রাইভ করে রাখে 10 বছর ফর ভেজিটেরিয়ানস ইট মাইট বি বিট আর্লিয়ার তো এবার আমার রুল এটা উইদাউট এনি গাইডলাইন
দ্য এক্সপার্টস রুল দ্য প্রফেসরস রুল
ভেজিটেরিয়ানস 5 বছর নন ভেজ 10 বছর দ্যাট উইল বি মাই টার্গেট I can defend it.
পঞ্চবার্ষিকী পরিকল্পনা বুঝলেন তো এনিওয়ে সো হ্যাঁ ইয়েস ঠিক লেটস গো অটোইমিউন ডিজিজ I think this is on type 1 diabetes. We'll go through it a bit fast. Screen people with type 1 diabetes for autoimmune thyroid disease soon after diagnosis and thereafter at repeated intervals if clinically indicated. Actually, how many type 1 diabetes who come to us are screened? What is your take on Irvanda?
The number one, not only thyroid, but we have to check for celiac
disease also.
Well. So these are the two things we should check in
but
type 1
ADA
diabetes.
says celiac if it may or may not be depending upon the symptoms.
Yes, because many patients with celiac disease may not have any GI symptom. So it is better, it is prudent that we should check for because it is very easy. You can check the anti-IgA antibody for the celiac disease. So it can be done almost every lab. So get a celiac disease and I usually check anti-TP antibody. So if there is anti-TP antibody is positive, then the thyroid function test, then I will go in reverse order.
Reverse order.
Yeah. So
But
first,
if it is normal, how frequently will you screen?
we should check once in a year, or you.
As for any anti-TPO positive patient who is euthyroid, you will go according to that.
Yes, anti-TP antibody positive, you can increase the frequency of tests. Say 6 monthly, you can test for thyroid function test. Otherwise, 1 year is good enough. I don't think more frequent is necessary.
Now we come to bones, diabetes and bones. What they say, treatment may be considered for adults with diabetes with a T-score between -2 and -2.5 in the presence of additional risk factors for fracture. Now, the question is what to take as cutoff. Is it -2 or is it -2.5 in T-score that is to be considered?
I think I will prefer to have a -2.
For diabetics, I think there are quite a lot of evidence which has come in which is
Yes.
telling that it is -2
-2.
and not.
But ultimately, I can tell here that we as a clinician don't see the bone health in a very serious way.
Yes.
And that is one thing we have to see in our patients. We always see the retinopathy, we always see the peripheral neuropathy, we always see the nephropathy. But bone health, I think most neglected part in our clinical practice. And that's why, because of the cumbersome, that is the T-score and something like that, it is not readily available in everywhere. So I think we have to go by this T-score in every patients whenever there is a frail score or something like that. We have to do the screening, doing the osteoporosis screening and giving the drugs appropriately. And that is most neglected part in part of the treatment of type 2 diabetes.
May I add that we never also recommended annual dental checkup.
Yes, another thing. Yes,
Dental
absolutely.
checkup is something which I have never seen in any prescription. Yeah, Kolanda. Bone. Now coming to MSALD, the disease of the contemporary times. So, what do you consider as this is the algorithm, how you go about do a FIB4, if it is greater than 1.3, how do you go if the LSM is greater than 8 kPa? It's all available. But what is the gold standard test you would do for the detection of fibrosis in a diabetic subject? Many viral infections lower platelets as a sequel and hence can skew the results of FIB4. What is the gap we should be giving between a viral infection and assessment of platelets for FIB4? And the third, does the ESSENCE trial carry forward a new hope? So going 1, 2 and 3, Kolanda first, gold standard test.
So, So I think there is one change, if I am not mistaken. So correct me if I am wrong.
This is 2026.
Yes. So one change. So FIB4 it is there. So FIB4 is the gold standard. So no question about it. এখানে অনেকগুলো
Gold standard is biopsy.
MRI PDSS.
Gold standard is biopsy. ওটা তো রইলই. Gold standard is biopsy.
Non-invasive,
Non-invasive.
MRI
So I correct myself.
MRI.
Gold standard is biopsy. That is there because we don't want to do biopsy. That's why all this there. So FIB4 is there. FIB4 involves platelet count. আমাদের দেশেই আসামে platelet count একটু low থাকে. অনেক জায়গায় platelet count low থাকে. We might get aberration in the interpretation of the results of the FIB4. So as to your very pertinent question, viral infection এ কবে? আমি উত্তর জানি না। I use roughly 6 weeks. আচ্ছা এবারে blood cells, red blood cell এর, if we look at the blood cell line, white cell, red blood cell, platelet, thrombocytes, red blood cell এর আমরা জানি 120 days, তো ওদের টার্নওভারটা খুব স্লো, সেই হিসাবে প্লেটলেটের টার্নওভারটা খুব ফাস্ট কিন্তু, so it will be very quick. So any insult you will also recover very quickly, but still I give it around 6 weeks time roughly for it to recover. So rough idea, কোথাও লেখা নেই কিন্তু কত weeks এর মধ্যে করতে হবে. Here now correct me if I am wrong, this is the one major change from 2025, যে FIB4 more than 2.67 হলে we will refer to the
Hepatologist directly.
না এটা 225 এর ছিল না, 225 এ যেটা ছিল যে FIB4 more than 1.3, LSM করো, LSM more than 8, এবার হেপাটোলজি। ওটা কি ছিল? এটা আমার মনে পড়ছে না।
25 ছিল এটা। Yes. The thing is
This
that
algorithm has been placed, it is there.
yes, the FIB4 score is basically a screening test, and you have asked for the gold standard for the fibrosis. I think fibrosis obviously the
MRI
MRI.
PDSS.
Yes. But the thing is that if the FIB4 score is less than 1.3, we can sit back and to allow the patient for another opinion for after 6 to 7 months. But 1 year. But the thing is that regarding the platelet count, it is not only the viral. I think different laboratory gives different platelet counts as far as the patient is concerned, depending upon that. That is also a problem in our clinical practice. That one laboratory give 1.2, one laboratory give the 1.6. So you have
Professor
to.
Shahad, I think those who do this by automated analyzer only,
Yes.
without a cross check,
Yes.
small size RBCs
I
are
know that.
also counted as platelets.
I know that.
And the number enhances.
That's the problem, because whenever you see the reports, I think all are having the complete hemogram. That means through the machines, not by the manual counting. Because
Only if
in
it is
cases
below
of dengue,
80,000
in cases
they
of
do it
dengue,
cross-check.
in case of dengue, we just say the platelet count by manual to see exact amount of platelet. But in cases of in this case, I think we always do the complete hemogram, which is done by the automated machine, and that is one important thing to be remembered.
আমি অ্যাকচুয়ালি ফ্যালাসিগুলোর মধ্যে যাব না। কল্যাণ ফ্যালাসি বলেছে, কৌশিকও অনেকগুলো ফ্যালাসি বলেছে। আমি বলবো এভরি টাইপ 2 ডায়াবেটিক সাবজেক্ট শুড বি স্ক্রিনড ফর লিভার ডিজিজ। এই জিনিসটা আমরা রেগুলারলি করি না। সবাই ক্রিয়েটিনিন মাপতে দেয়, আগে তো এসিআরটা মাপতে দিত না। 20 বছর আগে আমরা যখন শুরু করেছি এসিআরও মাপতো না কেউ। তো এইটা কনফারেন্স হয়ে একটা জিনিস হয়েছে, পিপুল আর মেজারিং এসিআর, দ্যাট আই হ্যাভ সিন দ্য চেঞ্জ। পিপুল আর মেজারিং লিপিডস, আই এগ্রি। সবাই যে কেউ ডায়াবেটিক পেশেন্টকে দেখলেও, কোনো ফিজিশিয়ান যদি দেখো, আমি দেখেছি সুগার, ফাস্টিং, পিপি, H1C। 25 বছর আগে 30 আমরা যখন ডিএম পাস করেছি লোকে H1Cও মাপতো না। যাক H1Cটা তারপরে অ্যাড হয়েছে। হ্যাঁ, ইয়েস, বিকজ H1C ওয়াজ নট রেডিলি অ্যাভেলেবল, ছিল না। সো H1C মাপা শুরু হলো। তারপরে যারা পুরনো ফিজিশিয়ান আছেন আপনারা মনে রাখবেন যে H1C আমরা আগে মাপতাম না। তারপরে ধীরে ধীরে এসিআরটা অ্যাড হলো, তারপরে লোকে লিপিড অ্যাডটা মাপছে মোটামুটি রেগুলারলি। নাও উই শুড লার্ন যে ডায়াবেটিক পেশেন্টদের আমাদের লিভার দেখতে হবে অ্যাজ এ ইনিশিয়াল স্ক্রিনিং। সো চেক FIB4 স্কোর লেস দ্যান 1.3, কিছু করার দরকার নেই। মোর দ্যান 2.6 হেপাটোলজিস্টের কাছে পাঠিয়ে দিতে পারেন। Between 1.3 to 2.6, get a fibroscan done to check the amount of fibrosis presence or absence.
I think before 2024, we also did not check the platelet, for which
Yes.
we couldn't do the FIB4.
Yes.
Majority of the times, we had a SGOT, SGPT, but we didn't have the platelet.
Yes, because FIB4 score was not highlighted by ADA
Anyone.
even in 2022 তে ছিল না।
না।
In 2024 they came with
In a big way.
in a big way regarding the liver guideline. Yes. না, ছিল না।
এই 2025 এ
না, 2025 এ 2.6 এ ছিল।
1.3 টা হলো গিয়ে তোমার
ওই আগে থেকেই আছে। হ্যাঁ,
ওটা আগে থেকে আছে।
আগে থেকে আছে।
তারপরে আচ্ছা দেখতে হবে।
24 এ বোধহয় ছিল না, 25 এ আছে।
আচ্ছা।
25 টা আছে আমি পাক্কা।
আচ্ছা
আমি আপনাকে যেটা পাঠিয়েছি ওটা 26, এখন যেটা
হ্যাঁ,
দেখছি।
না আমি 25, আমার বাড়িতে 25 টা রয়েছে না, ওটাই মাঝে মাঝে দেখি তো।
Although this is coming down more to the earth, glucometers, okay? Although blood glucose monitoring in people on non-insulin therapies has not consistently shown clinically significant reductions in A1C levels, it may be helpful when modifying meal plans, physical activity plans, and or medications. So, what are the scenarios? Question to all of you. Quick answers. We are running, just have 6 minutes time. What are the scenarios where you use glucometers while a patient is not on insulin? Not on insulin. Any কাউকে গ্লুকোমিটারে চেক করতে দেন?
Hypoglycemic
I think
Any
the
SU?
patients who are on the medications who cause hypoglycemia, we think if the patient has got the symptoms, we have to do that. things.
Acha, do current apps which give graphical representation of the data set provide adequate benefit over and above the values? Just কিছু কিছু গ্লুকোমিটার আছে তার অ্যাপে গেলে you get a
Yes.
graph.
And that is also very important because you have to see the trend and see the areas where we are having the hypoglycemic episodes. Then according to that, we have to adjust the dose.
আমি এই স্লাইডটা দিয়েছি একটাই কারণে, প্রচুর সময় পেশেন্টরা এসে আমাদের বলে এই গ্লুকোমিটারগুলো ফালতু, এদিকে কিছু হবে না। অল অফ আস এ তো ভুলভাল রিডিং দেয়। বাট ইফ ইউ লুক এট দ্য আইএসও, within 15% for blood glucose greater than equal to 100 and within 15 milligrams for blood glucose less than 100. তাহলে বেসিক্যালি ভ্যালুর থেকে প্লাস মাইনাস 15 ইজ দ্য রেঞ্জ, কারণ 100 হলে তার 15% অফ 15 milligrams. So, are all available glucometers alike? They are usually the feeling amongst persons with diabetes that glucose meters are inaccurate. How do you counter that? Kolanda has got innovative ways. He perhaps pricks himself and shows the blood sugar, as he does with the insulin syringe.
No, not the insulin injection. So available glucometers alike? No, they are not alike. There are differences in their methodology.
But if you see that many of the glucometers which we do not recommend, they also have the ISO.
They do have. So there is a feeling amongst people with diabetes that glucometers are inaccurate. There definitely is feeling. So I tell them that whenever you check your blood sugar by a venous sample, at the same time you check it by pricking your finger. মানে এইটা বলতে হবে আঙ্গুল দিয়ে দেখিয়ে, কারণ কি হবে ইফ ইউ টেল দেম তাহলে ওই ভেনাস ব্লাডটাই ওর মধ্যে দেবে, একটা বড় ড্রপ পড়ে গিয়ে রিডিংগুলো ভুলভাল হয়ে যায়। সো ইউ চেক ইট এট দ্য সেম টাইম, ইউ উইল সি ফর ইয়ার সেলফ। ইউজুয়ালি হোয়াট আই ফাউন্ড ফ্রম মাই এক্সপিরিয়েন্স ইজ দ্যাট দ্য পিপি সুগারের একটু ভেরিয়েশনটা বেশি হয়, ফাস্টিং সুগার মোটামুটি অ্যাকুরেট থাকে। তো বলে ফাস্টিং সুগারটা তুই চেক করবে যখন ব্লাড নিল সেই মুহূর্তে আঙ্গুলে এরমভাবে দেখিয়ে আঙ্গুল ফুটিয়ে তখন দেখবেন। দ্যাট ইজ দ্য বেস্ট ওয়ে টু ডু ইট।
Thank you. Being short of time, moving on to Professor Shah. Well, nutrition, physical activity, behavioral therapy. Weight maintenance programs provide monthly contact, very important, and other self-monitoring strategies like food diaries and encourage regular physical activity. Mind it, it is 200 to 300 minutes per week. It is not 150.
নট 150, এইটা নতুন চেঞ্জ হয়েছে। হ্যাঁ নতুন চেঞ্জ হয়েছে, এটা নতুন এসেছে 26 এ।
This is regular physical
আমি
activity,
দেখেছি।
200 to 300.
Not 150.
নট
Not
150,
150.
নট 150।
এটা 2026 এর guideline.
ইয়েস।
Okay?
আচ্ছা।
So now my question is, the weight loss trials chose 150 minutes aerobic activity rather than 300 minutes, especially Surmount 4 in the period beyond 36 weeks when the drug was stopped in 1 arm. So would it have been better? And second, they also tell that no nutritional supplements are not recommended. So the question comes as, do we prescribe nutritional supplements?
No,
Or we
generally
don't.
we don't recommend to give any nutritional
Any
supplement.
special situation?
Special situation means?
Inpatient,
Yes, that is different. That is not related to diabetes. I think
geriatric, EOL care,
that is different issue. That is depending on the patient.
standard OPD patients we do not prescribe.
not
They
recommend.
should be monitoring for all the powder affiliated practitioners. So nutritional supplements are not recommended even for weight loss, let alone be diabetes.
Yes. When you are saying something different, I know that. Why you are saying something this. But the thing is that regarding the changes in the exercise from 150 to 300, I think I don't have any insight that how it has been changed. Why it has been changed. I think I don't have any recommendation regarding the papers. আমি ঠিক জানি না এটা নিয়ে।
Actually, ছিল হচ্ছে 60 minutes. For weight loss, it was recommended that it is 60 minutes.
Okay.
এটা ছিল, it is there.
Previously what happens, the 30
মানে
minutes.
guideline এ ছিল না, কিন্তু
Guideline
papers
was
are
that.
there.
Guideline was previously 30 minutes, 5 days a week, not in a consecutive way. That is the guideline was there. Now it is having the 30 minutes, 300 minutes. I think we have to double that. 60
মানে
minutes.
আমরা কি, আমার প্রশ্নটা হচ্ছে যে 6 মাস মানে 36 বা 38 সপ্তাহ ওয়েট লস মেডিকেশন নিয়ে যদি 52 সপ্তাহ আমরা 300 মিনিট হাঁটি, আই থিঙ্ক দ্য রেজাল্টস উইল বি মোর দেন দ্য 9%, about 10-11% that
Probably.
residual.
Probably. I think it is a hypothetical question, so I cannot give you the exact